Thank you to Dr. Katsanos. I'm going to introduce him. He's obtained his medical degree from the University of Ioannis, School of Medicine in Greece in 2011, and completed his training in neurology at the University of Ioannis and at the National and Kapodistrian University of Athens. He completed his PhD in the Department of Neurology, the University of Ioannis, investigating the contribution of transesophageal echocardiography in the diagnostic workup of patients with stroke. In 2019, he commenced a stroke fellowship in the Division of Neurology at McMaster University and was appointed as an investigator in the Brain Health and Stroke Program at the Population Health Research Institute in 2020 and appointed as assistant professor at the Department of Medicine Neurology at McMaster University in 2021. His research focuses on emerging neurosonology applications and the evidence-based evaluation of novel therapies in acute stroke treatment and secondary stroke prevention. Dr. Katsanos has actively participated in numerous research projects and international collaborations. To date, he has published more than 250 papers in high-impact medical journals. Dr. Katsanos has been the recipient of the New Investigator Award from the Heart and Stroke Foundation Canada, the E.J. Morin Campbell Award from the Department of Medicine, McMaster University, and the Young Investigator Award from the European Stroke Organization, as well as the Outstanding Reviewer Award from Stroke, which is the official journal of the American Heart Association. Dr. Katsanos serves as an academic editor, associate editor, and assistant editor for various journals. He serves as a member of the Guidelines Committee and the Young Stroke Physicians and Researchers Committee of the European Stroke Organization, as a member of the Digital Content Committee of the Canadian Stroke Consortium, and as a member of the Communications Advisory Group of the Population Health Research Institute. And with that, I'll turn it over to you, Dr. Katsanos.
Yeah, thank you so much, Tina, for the very kind introduction. Thank you so much for inviting me. It's a pleasure to be here, and I'm always excited to present to this network. And feel free to ask any question, even interrupt me. I'm more than happy to have a lively chat and a lively discussion as I go through my presentation. So I don't have any conflicts of interest for this presentation, but prepare yourselves because we're going to talk about nasty things about brain bleeds and the neurons, unfortunately. So first of all, I think it's important to clarify some things about the terminology. So we're talking about intracranial hemorrhage. So intracranial hemorrhage, we're talking when bleeding happens inside the brain. So it can be anywhere. It can be inside the brain parenchyma, in the subarachnoid space, in the subdural space, or the epidural space. And this is called intracranial hemorrhage. So when we're talking about bleeds that they happen into the parenchyma, as you can see here, noted with the arrows, we're talking about intracerebral hemorrhage. So clarification: intracranial hemorrhage, bleeding inside the brain; intracerebral hemorrhage, bleeding inside the brain parenchyma. So I have to give you YouTube videos about intracerebral hemorrhage. So these were, in fact, real cases, and they were recorded live from a CAT scan that was done in one of the patients in the University of Ottawa from Dr. Dar Dalotai. I'll just have to find where the press button is. Here we go. So this is a live CT scan for a patient presented with acute stroke symptoms, and they give also contrast. So what you're going to see is active bleeding. So you can see here the bleeding. This is this area that forms this weird shape. What is happening is when they're giving the dye and they're doing the angiogram, the patient bleeds at exactly this time. So this is a very nice video because it gives us the explanation of what an intracerebral hemorrhage really is. It's a rupture of a brain vessel. So the brain vessel ruptures and causes bleeding inside the brain. We can see it very good in a CAT scan. So a CAT scan, one of the things that it can do really reliably is to tell you if there is blood inside the brain. So if a patient presents with acute stroke symptoms and you do a CAT scan, if there is a bleeding in the brain, it's really hard to miss it because you can see here this white hyperdense areas. This is bleeding inside the brain and this acute bleeding. And down from the images in the CAT scan, you can see autopsy images, how the brain looks after a brain bleed. So you can see here the destruction of the neurons and the blood in the brain in places where it shouldn't be. And as you can see, both from the CAT scan and also from the autopsy, brain bleeds, they look really nasty and they create a lot of damage in the brain. So to get a better sense about the pathophysiology of the brain bleed, we have to divide some stages in the hemorrhage. So when we're talking about acute hemorrhage is exactly what we did see in the video. So a vessel breaks and blood spits inside the brain. And as you can all understand and as you all know, our brain is a closed cavity. We have bones around our skull, so what happens is that, you have leakage of blood inside this cavity, which increases the pressure inside the head because the pressure cannot go into another space. So that creates elevation of the systolic blood pressure, decrease of the heart rate. That's the known Cushing's effect. You can have decreased level of consciousness. You can have nausea and vomiting as a result of the increased intracranial pressure. And many people with brain bleeds, they present with sudden severe headache onset and also seizures at onset. So these are the kind of like the red flags in an acute stroke that makes us think about brain bleed. But again, it's hard to say. It's almost impossible. In reality, when a patient with acute stroke comes, you need to get a CAT scan to see if it is an ischemic stroke or a hemorrhagic stroke. So the next phase after the bleeding stops, you do the CAT scan, the bleeding is there. So what is the next risk for the patient that you want to make sure that it's not going to happen is what we call hematoma expansion. So bleeding happens, the bleeding temporarily stops, and after a couple of hours, the bleeding can expand. So you can see here two different patients. The patient on the top row is a patient that had a stable bleed. So the first and the second CAT scan, they look more or less the same. In the second row, you can see that is different. So the patient presented with a small thalamic bleed. And in the next scan, you can see that this bleeding has evolved into a big bleed and also blood inside the ventricles. So that's what we call hematoma expansion, and it can happen up to a third of the patients. So it's pretty common, and most of the times it happens in the first hours after the initial bleed. That's why we need to be really mindful, and we really need to monitor closely the patients that present within the first hours after brain bleed to make sure that they're not gonna expand their hematoma. So we have developed some imaging criteria to see who is gonna expand or who is not gonna expand or who is at risk of expansion. But I'm afraid to tell you that these imaging markers have a low prognostic yield. So in reality, you cannot predict with confidence who is at risk of expanding and who is not at risk of expanding. The bottom line is that if a patient comes too early since the symptom onset and he's found or she's found to have a bleed, that you should keep a very close eye on here because there is a high risk of bleeding expansion happening. So after this phase, you see that the bleeding is stable, but what happens is that you have this hypodensity around the bleed, which is what we call the perihematomal edema. So this is a result of the toxic effects of the blood product. So the blood is in a space where it shouldn't be. So the normal room for the blood is inside the brain vessels. So if it goes outside, and if it is especially inside the brain, as you know, there is a blood-brain barrier. So our bodies see the presence of this blood as a threat. So they start an inflammatory reaction, and they're trying to mitigate this bleed. So that leads to destruction of neurons, and leads to this perihematomal zone, where we're going to discuss a little bit further on what it really means. And then the final stage is that when the bleeding resolves, the perihematomal zone starts settling down, the inflammation starts, attenuating. Then what happens is that, macrophages, they go inside the brain and they try to clear the brain hematoma, and you have the resolution of the brain bleed, and, the patients are left with a scar that we see in the subsequent scans. Just be mindful that, as we discussed, you have the immediate effects of a brain bleed and you have the secondary brain damage. So you have the immediate effects of the brain bleed, and these are the symptoms that we see acutely because, as we discussed already, there is increased intracranial pressure, there is disruption of the blood-brain barrier. But at the same time, when the blood products start degrading, that creates the inflammatory reaction that leads to more destruction of neurons. So bottom line, the most of the damage in the brain bleed happens when the blood spits into the brain. But unfortunately, that's not the only damage that the brain has. There is some damage which is accumulated over time and can be responsible for symptoms such as cognitive decline that we see in our patients after a brain bleed. So as we said already, a CAT scan is imperative for the diagnosis and also for the localization of the brain bleed. So you can see here the most typical locations. So it's either infratentorial or supratentorial, and you can see here the most common spaces is putaminal, lobar, thalamic, cerebellar in the pons, or you can have also intraverticular ICH happening. And so location is also really important because it implies different pathophysiological mechanisms. So when we have deep bleeds, the ones that we see in basal ganglia, in the thalamus, in the cerebellum, so these are mostly the result of chronic hypertension. So what happens is that as our blood pressure is chronically elevated, the small little vessels that we have in the brain that we call the perforators, they get damaged, and especially we call it lipohyalinosis. So they get more and more and more stiff. So what happens is that when you have a spike in your blood pressure, so the vessels, they cannot absorb this increase in the blood pressure, so they break and they create this bleed. So that's what we see as a mechanism in the deep bleeds. The ones that they are lobar, and lobar means that it's close to the cortex, the mechanism is different. So it is what we call amyloid angiopathy, and we're going to discuss a little bit more about it because I know that you all hear this word, or he has a brain bleed. It was amyloid angiopathy, but I want to make sure that we all understand what this really means. And interestingly enough, although in acute ischemic stroke, you have like different reasons, and you have like 10% being large artery atherosclerosis, 20% cardiobolic, 10% lacunars, and so on and so forth. If you put hypertensive vasculopathy and amyloid angiopathy together, you have 75% of the causes of a bleed, leaving 25% for other causes, such as vascular malformations. You have fistulas, which means connections of the arteries and the veins, which shouldn't be there. You have hemorrhagic transformation of acute ischemic strokes, either related to arterial or venous infarcts. You have vasculitis, which is inflammation of the brain vessels. You have a moya disease, which is a rare disease. So in moya, people, what happens over time is that their vessels, they get more narrow and narrow, and they form some abnormal connections that they're prone to bleeding. The other reason you may bleed in the brain because you have a coagulopathy, either you have an inherent coagulopathy, you have hemophilia, for example, or you acquire the coagulopathy either because you have DIC from an infection or a tumor, or you have thrombocytopenia, or because we're giving you anticoagulants or thrombolytics that make your blood thin. And of course, there are also underlying lesions such as brain tumor, aneurysm, that we do see in follow-up imaging sometimes. Drugs that are related to increased ICH use are the ones that they increase the blood pressure, as you see, is like amphetamines or cocaine. And let's talk a little bit about amyloid angiopathy. So what is amyloid angiopathy is that we have a substance in our brain which we all have, which is amyloid beta. So normally we're able to get and clear this substance from out of our brain. So in some individuals, and we don't know exactly the reason why, they're not able to clear amyloid. So that results into the amyloid getting deposited into the small vessels that they're close to the cortex. And it gives the appearance that you see here in this photo, which is under the microscope, that this amyloid, accumulates around the brain vessels. So it creates damage to the brain vessels and makes them prone to bleeding. So amyloid angiopathy, you can definitely do the diagnosis if you have autopsy. Then that's when you're certain about it. But of course, we don't wait for our patients to die to do the diagnosis. So we have developed some criteria, which is called the modified Boston criteria. And we use MRIs to say if the patient has a possible or probable amyloid angiopathy. And what we are looking, in fact, we're looking signs of previous microbleeds. So signs of covert bleeds that they happen in a patient at some point in the past. It's impossible to say when, but what that tells us is that the patient had a bleed, but it also has evidence of a previous bleed in the past, and that means that he has an ongoing process that make them prone to bleeding in the brain. And after excluding other potential diagnoses, the diagnosis is amyloid angiopathy. So you can see here in this MRI, and this is a special sequence that we use in patients with bleeds, which is called SWI, susceptibility weighted imaging. So this imaging is like a sequence that we use to detect paramagnetic substances. And blood, when it breaks down, it gives hemosiderin, which is a paramagnetic substance. So you can see in the big circle up in the right that it's the fresh bleed. It's a big bleed. It's in the frontal cortex, and you can see also in the small circles, small round shaped things, which are what we call these microbleeds. These are the covert bleedings that they happen at some point in the past. So based on the Boston criteria, this patient has a lobar ICH, and also he has a presence of previous microbleeds. So he falls into the category of probable CAA, provided that the patients are more than 55. Because less than 55, we haven't validated the criteria yet. So that I think makes the point that when we are asked who should get an MRI, I would say that every ICH patient deserves an MRI at some point. Why? First of all, because you need to make sure that they don't have underlying amyloid angiopathy, especially if they have a lobar ICH. It's really important to rule out this diagnosis. And there is also an unexpected diagnosis in one of the third of cases. So although bleeding may seem to be a typical bleed, like a typical lobar bleed or a typical thalamic bleed, after you do an MRI in follow-up, you find that this patient has an underlying tumor, or there is something else over there that, because the blood was covering, you weren't able to see in the first scan. When there are a typical size of the ICH, multifocal locations, and a lot of edema, you're more suspicious, and you should definitely pursue to get an MRI. And this is a recent meta-analysis that we did with colleagues from Harvard. And what we did find out is that in patients that they got MRI after a brain bleed, we were able to find lesions in 1 out of 10, so 11%. So bottom line, almost all patients deserve to get an MRI down the line to rule out lesions and to confirm the diagnosis of amyloid angiopathy. And moving slowly to the from pathophysiology to epidemiology, when we're talking about risk factors, I would say the most important thing is hypertension. We know that there is a very close and strong correlation of hypertension with brain bleeds. And there is a deadly combination of increased blood pressure with alcohol consumption. So I can tell you that a lot of patients that I do see with brain bleeds, they have this really bad combination of untreated hypertension. So they are non-hypertensives, they're not taking their meds, and they are consuming excessive amounts of alcohol. Low total cholesterol is another mechanism that leads to increased bleeding. And probably in our rounds, you have seen us talking about whether statins they can increase the risk of bleeding. There are some ongoing research about this perspective. Smoking is also related to increased risk of brain bleed. Illicit drug use, and as we said, drugs that increase the blood pressure, such as cocaine. We know that elderly are at high risk of getting brain bleeds. The brain vessels, they become more stiff, and especially the penetrating arteries. And we know that Asians and males, they have a predominance for brain bleeds. And of course, genetic risk factors also have a share in here. We have patients that that their parents had a brain bleed when they were really young. So now we're moving from pathophysiology to epidemiology, which is another Greek word. So what epidemiology really means is that to study of a condition that falls upon the common people. So you have epi, which means upon, so you're really over and taking a really close look. Demi, which is like demos, which is the people, and logi, which is the study. So epidemiology is as if you're like in a helicopter and going around the forest and try to collect as many information as you can. This is from a study done in the US. It's very recently published. So what we know, as we discussed already, is that the incidence and the risk of getting a brain bleed and in cerebral hemorrhage increases with age. So you can see here the abrupt increase when you go from your 50s to your 60s to your 70s and to your 80s. So you can see this steep increase in the incidence of a brain bleed. The other thing that we do know is that the overall incidence of ICH is going up, and we're gonna explain why is this happening. So although we are better at treating hypertension and we're better at controlling risk factors, we can see that we have a gradual increase in the incidence of intracerebral hemorrhage over the years. However, if you look at the left diagram, if you adjust it for age, you see that the incidence starts going down. So that gives you the answer that probably the increase that we do see is related to the increased age of our population. And of course, here you can see on the panel B, as we discussed already, the difference in the risks about from when you're 40-year-old, which your risk is pretty low, but how it exponentially increases as your age increases. And you can see here in the gaps that there is a big difference if you're in your 70s and if you're in your 80s. So moving from the 70s to the 80s, you can see this big jump in the ICH incidence, and I would say almost it's almost double the incidence. So talking about males and females, as we discussed already, males are at a high risk of getting brain bleeds during their lifetime, and females have a slightly lower risk. But you can see for both sexes, the incident increases over the last decade at least. And why is this happening? I think we discussed it already. So you can see here these diagrams that show the breakdown of the population by age groups, and that was from 2000. So you can see that the percentage of 65 years and older was around 12%. So if we go 10 years later, that increases to 13%, and you can see how this graph moves from down to going up. So from less births and more people living longer and reaching to their 70s, 80s, and 90s. And when we're talking about 2020, you can see the difference that goes up to 17%. So you have even more people in the age of 70s, 80s, and over the age of 90s. And again, the births they stay the same, or they also decrease in developed countries, but people they reach higher ages. And when we're talking about projections, and this is the projection for 2030 and 2050, you can see that this problem is going to get even more in the coming years. So you'll have a lot of people living to their 80s and 90s, and of course you're going to say that this is not a problem. This is great, and I do agree with you. That's why we're here for, to make sure that people, they're going to live into their hundreds and even more than that, but to live healthy without disability. So what happens is that this increase in the patients that they're over 80, they put them at risk for having an intracranial bleed, which is significant. And when we're talking about the global incidence, so you can see here the world map. So blue are the places where the incidence rate per 100,000 people is less than 15 cases, and you can see that in North America and Canada, most of the U.S. and Canada, they have a low incidence of ICH, and most of Western Europe. So light blue, it's something like an intermediate. So you have an incidence between like 20 and 30 cases per 100,000 people. And when you start looking at things that they look as yellow or red or dark red, we're talking about like really high incidence of intracerebral hemorrhages. And you can see that those places, they are sub-Saharan Africa and also Southeast Asia. And I can tell you that intracerebral hemorrhages over there is a pandemic in that area of the world. And you can see that from this table over here. So when we're talking about Western Europe, North America, and Australia, so ICH is in fact 7% of the strokes we're getting. Let's say up to 10% to be a little bit more liberal. But when we're looking at Southeast Asia and Africa, it's almost a third of the strokes. So although we think, and that's the title of this series, that ICH is a less common stroke presentation, yeah, that's true. But that's true for us, for Canada. But when we're talking about South Asia, Africa, and even like China or South America, this is very frequent. It's not uncommon at all. And this is a very nice study done in Ethiopia and in Tanzania from one of my colleagues, Sarah Matula. What it does so is that people, they're not only getting hemorrhoids at an increased rate of 30%, but they also get their first ICH really young. So they get their first ICH when they're 48 years of age, and of course they get also their ischemic strokes really at a really young age when they're in their 60s. And you can see also that except for Ethiopia, that's the same situation also in Tanzania, where the incidence of hemorrhagic stroke and cerebral hemorrhage goes up to 40%. So why is this happening? Of course, genetic factors, they are coming into play, but unfortunately, the primary prevention is thin, if non-existing, in those countries. So there are many people that they have hypertension, which is not diagnosed, and if it's diagnosed, it's not treated. And of course, they have also other risk factors, as we discussed already: diabetes not treated, alcohol use, and many of those people, they have also rheumatic heart valve disease, and they are on warfarin treatment, and it's hard for them to control it. So they have this volatile INR. The INR goes up, and together with untreated hypertension, as you can understand, it creates a deadly situation for those individuals. So and again, as I mentioned already, it seems that there are, like, on top of the additional vascular risk factors, such as the hypertension and the the increased use of warfarin because of rheumatic valve disease. It seems that there are two racial disparities, as people that they have like Asian descent, they seem to have a higher risk of getting an intracerebral hemorrhage if you adjust for other risk factors in epidemiologic studies. The other thing that we do see is that there is also sex disparities. as we said already, men, they have a higher risk of getting an intracerebral hemorrhage in their lifetime. But you can see also that there is difference here between sexes in different races. So you can see the gap is much wider in when we're talking about the white race, and it becomes smaller when we're talking about patients of Asian and Chinese ancestry. So the problem with ICH is that it creates a lot of burden. So although we're talking about a third of the cases on the worldwide basis being intracerebral hemorrhage, they create a lot of disability. And disability, we measure it in what we call a DALY, or disability adjusted life years. So what is disability adjusted life years is a measure we use in epidemiology, and we are trying to capture the overall burden of disease. So it has two components. It has the years that you lived with disability. So, for example, when you're born, your expected lifetime is to live up to the age of 80, right? So if you have a bleed in your 50s, and you live from 50s to 70s with not being able to walk or take care of yourself, that's 20 years of disability. And if you die in your 70s, you'll have 10 years lost from your expected lifetime, compared to how your peers are expected to live during that time during that decade. So that's how we measure the disability in patients with strokes, and of course other medical conditions too. So, and again, the bad news over here is that people in sub-Saharan Africa, and also in Southeast Asia, but also, as you can see here, in North America, it's not only that they have a higher incidence of intracerebral hemorrhage. What happens is that their disability from intracerebral hemorrhage is really, really high. And part of it is because unfortunately they don't have the services to support them after the ICH, so they don't have in hospital settings that they can provide some measures to reduce disability, such as blood pressure control, or even control of the infections. And also rehabilitation is scarce and sometimes non-existing. So as you can see here, and this is a point that we all need to realize and take into account, is that ICH is a big problem. It's an endemic disease with really bad consequences for the population in low, middle income, and low income countries. So as you can see here, we think that patients with ischemic stroke, they have a high burden of disability, and this is true, right? So patients with ischemic stroke, they do have a high burden of disability, and we do see this every time we have a patient with acute ischemic stroke, that they have to undergo rehab, and that sometimes, unfortunately, they carry their disability throughout their lives. But we do see this more often because ischemic stroke is more prevalent, so it happens more oftenly. So when it comes to intracerebral hemorrhage, although it is less frequent, you can see that when we're talking with disability, the burden is much higher. So although you get less patients with intracerebral hemorrhage in your stroke unit in your hospital, the reality is that those patients contribute more to the disability of your population if they don't die. And talking about death, most of the patients with hemorrhagic stroke, they're gonna pass away during their follow-up. And the in-hospital mortality, or the 30 case fatality, can be as high as 50%. So you can see here how the mortality rates are stratified by age groups, and that's a study from Korea. So if you get an intracerebral hemorrhage when you're in your 40s, your chances of dying are around 20%. But when you get it out after the age of 80, your chances of dying are more than 60 or 70%. So you can see here that compared with ischemic stroke, the fatality after an intracerebral hemorrhage is much, much higher. And again, talking about developing and developed countries, when you're talking about the incidents, we did see in the global maps that there is a great disparity and a big difference between high income and low, middle, or low income countries. But when we are talking about mortality, that's even more pronounced, and you can see here how the lines they separate between developing and developed countries. So bottom line, low income countries increase the incidence of ICH, increase mortality, increase disability compared to high income Western countries. So your next question is that, okay, so what have we done over the years? So is the case fatality of ICH getting any better? So the medicine is advancing. We know that in acute ischemic stroke, we are seeing this reduction in mortality. So what about ICH? So I can tell you that I'm not sure about it. So there are contradictory data coming from different countries based on the population and the registry that they are analyzing. So for example, in this graph, in this slide, you can see two graphs from Norway and Texas that they say that there is no difference. So the mortality is the same. The case fatality remains constant around the year. So it's like between 20 and 30%. So no big difference. However, in France, in the zone area, what they do say is that there is some light at the end of the tunnel. So we did see a drop in the mortality of ICH in between 1985 and 2011. So again, if you ask me what is the reality, I think I'd like to say that I'm optimistic that probably there is a change which is not substantial, but I would definitely need more data to come and see in a global basis how is the case fatality really trending at. Because from the last report that we had, which is outdated, the message was that there is no change in the global fatality from intracerebral hemorrhage. The other reason that we do see increase that we don't see the change in the fatality is that because our population is getting older. So I just remind you of the previous graph that if you're in your 80s, your chances of dying is like 60 to 70%. So although you can take all the measures and treat infections, do DVD prophylaxis, do aggressive blood pressure control, these patients they don't have a good outcomes and they are at high risk of dying. So maybe that's why we don't see this signal that we wanted to see over the years. And the other reason is that we have patients that they are older and they are taking blood thinners. So when you're taking a blood thinner, if it is a NOAC, one of the known and newer oral anticoagulants, you have a 0.3% risk of bleeding to the brain. And if you're taking warfarin, it's 0.6%. So if you bleed on either of them, we know that this is not going to end up really well. So the case fatality, if you bleed in the brain while being on a blood thinner, is 40%. If provided that you don't get any specific antidotes for that. And your question is that, okay, we talked about the global scale, but what happens in our area? What happens in Ontario? So this is a very nice publication. So they looked at the ICH incidents over a decade between 2009 and 2019. So it was a retrospective cohort study. So the ICH incidence in Ontario during that decade was 19 cases per 100 person years. And what it did find out is that this incident is constant between these years. So they didn't see any major disparity throughout the years. They calculated that in-hospital mortality is around 30%, which is in line with what we see in Norway and also in the US. And the one-year mortality goes up to 45%. So what they did see is that between that decade, between 2009 and 2019, So they did see a reduction, and that's a positive thing, in both in-hospital and 1-year mortality. So they did see that in-hospital mortality decreased by 10%, and 1-year mortality decreased by 7.6%, which is not insignificant. One thing which is really alarming, and which is the frank reality that we all need to understand, is that only 14% of the patients, they were discharged home independently. So although mortality may be reduced in Ontario, disability is still a big thing, because most of the patients, most of the ICH survivors, they will not be able to live independently. And going to the costs. So this is another analysis. So this is from Alberta, and what they did find out is that the cost was highly variable. So the median cost per discharge was, you see here, around 10 grants, and it ranged from as low as 363 up to 265K. And we're talking about US dollars. And what they did find out is that the total cost did not change significantly during the decade. And patients that they were older, and they had in hospital mortality, they had lower costs. And you can understand that from a systems perspective, it's unfortunately cost saving if the patient dies in the hospital, because morbidity and all the other complications from ICH, they mean rehabilitation, they mean additional expenses, because these patients are coming back with complications. And what they did also find is that higher costs were also found in patients that they were undergoing surgery, and also surgery is also associated with complications, and patients that they presented with with increased neurological severity, and of course that makes sense. So one thing that we have been discussing about intracerebral hemorrhage is whether we're suiting ourselves in the food. So whether when you see a patient with ICH, you say, oh, nothing can be done, and this patient is not going to do well. So why bothering doing surgeries, treating blood pressure, treating infections? So we do know that we tend to embark in goals of care discussion much sooner and more easily in patients with brain bleed, and compared to ischemic stroke. One of the reasons that this is happening is this famous ICH score. So this ICH score is a prognostic score that takes into account your presentation. So how is your Glasgow Coma Scale? So if it is less than 13, you get some points. How much is the ICH volume in your CAT scan, and how much if you have presence of blood in your ventricles, if your brain bleed is inside, up or down the tentorium, and if you're more or less than 80 years of age. So when you see here, when your ICH score is 0, your chances of dying are almost 0. But if it's 3, the chances of dying, they go up to 70%. And to accumulate a score of 3 is not very hard, right? So if you're more than 80 and you have a stroke in the cerebellum, and your Glasgow Coma Scale is 12, so you accumulate the 3. So you go to the family and you say, you're below 1 based on this publication, and the score has a 70% risk of dying. And the family, they get really sad, and that's where it all starts about the self-fulfilling prophecy. However, in clinical practice, what we do see is that some of those patients, I'm not talking about all the patients, they bounce back, but if you give them some time, you see that there is some improvement over the next days. And when we're talking about death, the leading causes of death in ICH survivors, in fact, the vast majority is infection. So those patients are at risk of aspiration pneumonia, UTIs. Recurrent ICH happens in around 14%. Cardiac disease and ischemic stroke, it's another 14%, and respiratory failure is another 8%. So as you can see here, this explains also the high rate of death in ICH survivors in low, middle, and low-income countries, because unfortunately there is no infection control in those countries. And one of the areas I'm particularly interested is the risk of ICH survivors. So you have a patient with intracerebral bleed, so they were able to survive from it, and they now finish their rehabilitation and they're now home. So does the problem stops? No, not really, because those patients, they have other cardiovascular diseases, and they are at risk of getting an MI and a stroke and other bad things happening from them. And you're in a very nasty place where you want to give aspirin, but at the same time you're afraid because they just had a recent bleed, and you're trying to balance between the risk of having an MI, for example, and the risk of like getting another brain bleed. So you're between like a rock and a hard place, or what we say in Greece, like between Scylla and Charybdis. So it's a really tricky situation. And we know that patients after an ICH, they have a 3 times higher risk lifetime for a vascular event happening, including both an MI and also ischemic stroke. This is a study from UK, so that's the Oxford Vascular Study, and they analyzed almost 700 patients with intracerebral hemorrhage, that they were taking antithrombotic therapy before for a reason they had a previous MI. And what they did find out is that only in 6% it was continued after discharge from hospital or clinic. So it does show how reluctant physicians are to continue antithrombotic regimens for patients that they have an indication. And the reason for that is because we know that when you have an ICH, you have a 3% risk of bleeding again in the next year. And at the same time, we know that you have an 8% risk of having a vascular event, which is another ischemic stroke and MI, or to have a vascular death in the long run. So you're trying to juggle with those two numbers, and in fact, it's really hard and challenging to individualize and make a guess, like an educated guess, I would say, on what is the best for your patient, to continue the aspirin or just to drop it. And again, as you can see on the left graph, the risk of recurrent ICH, there is a difference between lobar and non-lobar. So if you're suspecting that your patient has underlying amyloid angiopathy, this 3% may go up to 10%. So it is really hard to make decisions. And I can tell you that unfortunately we don't have robust evidence from clinical trials to answer this question. There are unfortunately studies going on this perspective.
Dr. Castanos, I just wanted to say there's a question which I think you may have covered in the chat that's
Yeah,
come up.
I did see the question, so that's why
Okay, perfect. Okay,
yeah, so
thank you.
that's why I mentioned about the clinical trials, is because we don't know. We take educated guesses at that point. So we take our best guesses, saying that maybe amyloid angiopathy, maybe your risk of bleeding is really high, and you don't need the aspirin so badly. But if you're we think that your bleeding risk is lower and you had a very recent MI, we just bite the bullet and we give you aspirin. So, and again, these are all educated guesses based on pathophysiology, literature, epidemiology, and I hope the definite answers are going to come from trials that they're ongoing. And I'm going to touch a little bit upon the cognitive decline part, because we do see that patients in follow-up, they have a brain bleed, and they're seen in the clinic, and they have this progressive cognitive decline. And we do see that this quite often. It's a combination of vascular events. So those patients, if they have an MI, we know that they have a drop in their cognition, but a part of it we cannot understand, and we think that it's associated with this ongoing inflammation, this secondary brain injury that we were discussing. And you can see here a very nice graph about the cognitive impairment over time in a patient with ICH. So the first days after the ICH, you have this big drop in your cognitive abilities, and during the rehabilitation phase there is some recovery of it, but unfortunately for most of the patients you don't reach your previous capacity. So just to conclude, and I'm looking forward to questions in the Q&A or the chat box. So take-home messages: the two most common causes for ICH is hypertension and CAA. You cover 75% of the reasons. ICH is expected to increase due to aging of the population. Mortality and disability from ICH is higher in developing countries. It's an endemic, and ICH survivors, they're at risk of vascular events and cognitive decline. And the last thing is that we all know that cold stroke is both for ICH and acute ischemic stroke. But when we see an ICH in the CAT scan, we just take a pause and say, oh, it's not a stroke in an acute ischemic stroke, so no thrombolytics, no EVT, so we can take a rest and I'll grab a coffee, which shouldn't be the case, right? Because there are things that we can do, and I'm sure that you're gonna cover in the next lectures that you're gonna be receiving, because everybody is keep talking about now the code ICH, and we should not push the brakes, but in fact we should continue as we're doing for acute ischemic stroke. And I would like to thank you all for the attention, for the kind invitation, and I'm looking forward to discussion and questions.
Are there any questions for Dr. Castanos? You can put it in the chat or raise your hand.
Dr. Katsanos, if you're able to give control of the screen back to
Oh, yeah, for sure. Yeah. Give up remote control. Okay. And please ask anything. So I'm more than happy. That's why I'm here for.
Okay. Yes. Thank you, thank you, Dr. Castanos. I loved how much you anticipated a questions. You even told us you would probably be asking this and asking that. So that was excellent. I thought I saw a hand raised at one point. So if somebody, that's another option. If anyone would like to raise their hand and ask a question, they may do that. You'll see that in the chat box, there is the link to the evaluation, which we would really appreciate. It's a very quick evaluation there. So there's just a couple of minutes. Well, if anybody does have any other questions.
I have a quick question, Tina, if it's okay.
Yes,
So Dr. Katsanos, thank you so much. That was an amazing talk. And as you were talking about the prevalence of hemorrhagic stroke, I wonder if you think that there are key messages that we could share with the public that would be important for us to use in public awareness campaigns specific to risks related to hemorrhagic stroke.
Yeah, thanks, Steph. That's an excellent question. So what I always tell my patients for primary prevention, and we know that from studies, and we have robust data for that, is that for ischemic stroke, but mostly for hemorrhagic stroke, the most important thing is blood pressure control. So control your blood pressure, and the second thing specifically for ICH, do not drink, right? Because if you are hypertensive and you drink more than a couple of drinks, then what happens is that your blood pressure shoots up and you're at a really high risk of getting a brain bleed. So untreated hypertension and alcohol consumption, I'm talking about excessive alcohol consumption, is a deadly combination. I cannot tell you how many patients I have with this combination.
Dr. Castanos, I had a question
Yeah.
that you were looking at and sort of wondering if there's suggestions or strategies for, how do we prevent sort of that self-fulfilling prophecy with some of that prognostic scores early after ICH? What's that balancing factor?
Yeah, that's an excellent question, Rhonda, and I think we're shifting our minds, right? So now there are interventions for ICH. So we know, for example, for sure that blood pressure control in the early stages can make a difference. We have trials now that they are positive for evacuating the hematoma. We have positive trials. One of them is done out of PHRI, that if the patient is taking, for example, one of the blood thinners, if you reverse it, you're decreasing the risk of hematoma expansion and disability and then hopefully mortality. So I think the field is changing, and you know that really well, Rona, because you've been around for quite some time now. That the differences that we had in acute ischemic stroke, this time is brain, it was based on TPA, right? So because we had a treatment and we know that we had to pull up our socks and start running, I think the same is happening now for ICH, and in fact it's happening because we have treatments now. And so I think this self-fulfilling prophecy is kind of like an old school attitude, and I don't think it's going to be valid for a long time.
Great, thank you.